Hello. Hello. Yes, working. Yeah, good morning, doctors. I hope all of you are doing fine. Please forgive me that last week we didn't make any teaching. However, this is a compensation of the last week teaching. To be rather short, okay, but very important, I guess. It's discussing the topics that usually I find the candidates are struggling in the exam regarding it. But first, before going through what I needed to speak about today or lecture about today, is I want to talk about because a lot of people are depressed, a lot of people are worried about what is next step in the future after the exam, and they didn't still finish their exam yet. Well, this is not the way of the not the right way of thinking, please. Okay, don't listen to the negative thoughts and the negative talks around that. Oh, there's no opportunities for GPs in the UK to work. That's not true. Yeah, maybe the work, the work market become more competitive, less locum work, more GP salary work, part-time work. Yes, that's true. Okay, there is 24 hours, out of hours, also GPs is there always. Okay, and as well as, the overseas market, okay, either in Australia, Canada, US, and Middle East, especially in Dubai. And you can see the beautiful scene behind me, okay, where the Dubai city is, and, and attending the Arab Health Conference, which is showing a big opportunities in the future for the NHS doctor to work here. So please don't think about the future, just think about the current time. Think how to finish and pass the exam, and after the exam, I promise that you will be able to find work. Okay, and there is loads of opportunities, loads of of types of work. Even you can become engage in teaching, engage of supervising, engage of becoming, TBD, become e-portfolio GP. A lot of opportunities in the GP land. So just finish your exam, focus on your exam, and finish it, and then think about the next step, and that's will come, and it will be an easy step. A lot of doors, a lot of opportunities. So don't listen to the negative thoughts. Don't listen to people that, oh, they couldn't find work. No, you will be able to find work, okay, but you will not find the work in the place that you want. Okay, if you have prerequisite and you have conditions and you have this and that, then okay, then it's fine. Either you can just make your condition easier, or just forget about some of your conditions and be more malleable, and for sure you will find work without doubt, with a lot of opportunities, a lot of opportunities. So please don't be negative, don't listen to the negative thoughts, and stay focused in your exam. Okay, uh, let's see my lecture today. So my lecture today is just an introduction of what our webinars or what our courses are presenting in the ethical point of view. Okay, what are the ethical cases or dilemma that I usually teach in my courses? Okay, so the heading is what is the difference between respect form and DNR form? Okay, and what is advanced directive of refusal of treatment, statement and decision? Okay, and what is the difference between the statement and the decision? And what is the alternative name of it, which is the living will? Lasting power of attorney, when it's valid and what type of it, and when to consider it, okay? And also for sure discussion about the child in needs and safeguarding of childhood, safeguarding of adulthood, and also unique cases about when are the coroner talking to the GP and what he needs from the GP and what is the interaction, because there is a close interaction after you finish your qualification between you and the coroner, and both of you are supporting each other in critical decision making. Okay, and also the midwives, okay, and other the community team members, midwives, and district nurses. So if you are talking with a midwife regarding safeguarding with the pregnant lady and her children, or specific complication of pregnancies, and she call you to discuss with you, or result of urine during pregnancy, or result of swabs during pregnancies. Okay, this you need to be aware about it. When are the conditions that the midwife could interact with you, and then caring of dying patient in community, or terminal disease in the community, okay, either cancer or either advanced Parkinsonism, or advanced dementia. Okay, what are the medication, what are the doses, and how to do, just in case medication, continuous infusion medication, syringe pumping medication, how to write them, how to interact with, the community palliative care team nurses, and what are the interaction between you and them, and loads of other case scenario that I'm discussing in my courses. The other thing is female genital mutilation, ethical things regarding children. Okay, all of this are discussed. Today we will take one example of it, okay, which is if a, wa- if a, if a wife of a patient of terminal disease, or advanced priority calling or discussing with the GP, okay, respect form or do not resuscitate form on behalf of her husband or behalf of her patient, how we can respond, how we can negotiate that with her without breaking confidentiality, because confidentiality here will be a big aspect that we need to respect. Okay, so I think we need to listen to the conversation. Okay. And also in the conversation we'll have script, because a lot of doctors was asking me about if the conversation and the things are written, maybe that will be easier for them to study. But please be aware about that's not a script to, to save and just focus on it. No, you need to have your own way of expression. You need to have your own signature on each consultation you are doing. Otherwise, there is no it will be meaningless to teach you in such a way that you need, to save scripts. Okay, because each doctor is different, and each doctor has his own way and own flavor.
Hello there. Is it Mrs. Smith?
It is.
Hello,
Yes.
I'm Geordie Morell. I'm one of the nurses have asked me to come and have a chat with you.
Yeah, I want to chat with you, but I don't want my husband to know I've had the chat.
Okay.
Okay. 1 minute. If it's something in the system.
Hello there. Is it Mrs. Smith?
It is.
Hello,
Yes.
I'm Geordie Morell. I'm one of the nurses have asked me to come and have a chat with you.
Yeah, I want to chat with you, but I don't want my husband to know I've had the chat.
Okay. Fine. Just before I carry on, obviously there is an issue of confidentiality, and I've not spoken to, obviously not warned him that we're going to talk. So, in terms of specifics about his illness, I'm fine.
Should be working now, hopefully.
Hello there. Is it Mrs. Smith?
It is.
Hello,
Yes.
I'm Geordie Morell. I'm one of the nurses have asked me to come and have a chat with you.
Yeah, I want to chat with you, but I don't want my husband to know I've had the chat.
Okay. Fine. Just before I carry on, obviously there is an issue of confidentiality, and I've not spoken to, obviously not warned him that we're going to talk. So, in terms of specifics about his illness, I'm restricted in what I can what I can tell you, but I think we can talk.
I'm not going to ask you questions about his illness.
That's fine. That's fine. Please.
And I think I know it in any case. So, you know, we can just sort of go from there. I'm getting increasingly disturbed. He's been in 20 times.
Gosh.
And each time he comes out a bit worse than before.
Right.
And to be honest, we're not managing at all. Okay. I mean, I've got arthritis of my back and knees as well as angina, and I can't cope with him.
Okay.
For his part, he's very depressed and he has no quality of life. Our highlight is to come to outpatients as a trip out in the ambulance. That's the only time we really get out now.
Oh, I'm sorry.
But it sounds absolutely dreadful. Next time this happens, can you just let him go, not resuscitate him? Now, I know you're going to say you've got to discuss this with him, and that's fine, but I don't want him to think I've said it.
No, that's you know, in the same way that what I know of him is held in confidence. You know, this I'm happy that I'm having this conversation's in confidence also.
Yeah.
Now you said previously you were not coping. In what sort of way?
Well, he's sort of totally housebound, and he's really needs help moving around and things now, and I just can't do it with my arthritis. I'm almost reaching the point I need help moving around, you know, and it's difficult.
Yes.
But the very worst thing is his depression with the whole thing, because he's just totally fed up of being shut in the house.
Yeah.
Don't think he altogether realises I'm shut in with him, but you know, as I say, coming to hospitals our highlight.
I can see that
if it's not admission.
It must have been incredibly hard for you up to this point, and I think it's very brave of you to come forward and I'm grateful to you for coming and telling me how you feel. And when it comes to, you know, obviously it's obvious that you care about him a great deal, and you have been.
Yeah. Well, yes. I mean, I think I have worked very hard with him, but I think I might be coming to the end of what I can do.
Well,
and the other solution is for him to go into a nursing home, which, I mean, we can't afford anyway, but I'd hate that even more.
Well, I can see this is obviously, it's very distressing for you to even have to talk about this sort of thing, and, you know, to have got to this point where you've been caring for him for such a long time, and it's important that you do acknowledge that there are limits. You're not superhuman. You need help in the same way as he needs your help. So now, coming back to the what you said before about letting someone die, that's, you know, I can see that obviously it's quite an emotional statement, and just to clarify what we're talking about here, you mean that's
resuscitation.
Okay. I think, and it clearly shows how much you've been in hospital, because a lot of people wouldn't understand the sort of the processes. So the automatic sort of default position when a patient comes into hospital is that they are for resuscitation until we make a decision not to resuscitate.
Yeah, I don't actually know much from coming to hospital. Right. It's largely what I've got on casualty and Holby City, but
don't believe everything you see.
Well, no, I know, but I did wonder. Each time he comes in, he's much worse.
Yes,
and I think it might get to the point of resuscitation. And I was thinking it was perhaps time that somebody here broached it with him and what he would wish to do.
Well, just to sort of set the ground, if you like, the resuscitation, what we're talking about is cardiopulmonary resuscitation. That's the long-winded name for it. People hear about it as CPR, and that's essentially what it stands for. And that's the business of the chest compressions and mouth-to-mouth, or in hospital we've got equipment, so we don't need but this only really happens when someone dies. So it doesn't affect anything that happens up to that point.
No.
It doesn't limit what treatment they receive. It doesn't limit how aggressively we treat someone. But it means that when they die, we leave them dead. We don't try and bring them back.
Yeah, well, this is what I'm talking about.
And I think the person you're describing to me sounds like someone who would not survive a resuscitation attempt. And I think it's probably a very sensible decision that, you know, that in those rare cases where someone does, because again you've mentioned, you know, possibly two of the worst offenders of misrepresenting resuscitation on film.
Well, you have disappointed me.
I'm sorry.
Well, I enjoy those.
I don't want to knock your enjoyment of them, but if you look at TV, the success of resuscitation is very, very high. The reality of it in hospital is very, very low. We're talking, you know, 10 or 15% of people survive resuscitation. So it's very, very low indeed. And people who have a chronic illness, the likelihood is even lower. So the chances are that he wouldn't survive resuscitation. But that's not what I'd be most worried about. I'd be most worried, as you're sort of alluding to, that if he did survive, he would be severely brain damaged, and he would be even more dependent on you than he is now. So that's why I would make the decision. Now, the decision to resuscitate or not is down to the doctors, down to the medical team.
I thought it was fun.
So it's neither your burden or privilege to make that decision.
It wasn't mine. I was hoping
now,
my husband would come up with it himself.
It is good practice to discuss it with the patient themselves. So with your well, I'd say blessing, but I hope you will understand that I have to talk to him about this.
Oh yes, you do. Yes.
Yes. And rest assured, I will couch it in very sensitive terms, as I've talked to you about. And I don't want to alarm him or worry him. I want to explain that we are going to treat him fully.
Yes. Yeah.
Up to the point where he dies. And when he dies, I want to allow nature to have taken its place, you know, and just not interfere really
afterwards.
And I will say to him that it's something that won't work, but it's not something that he'll be aware of at that time.
No.
You know? So we'll manage it as sensitively as we can.
Yeah.
But it is he has often, when we talk to people when they come into hospital, if we're not, as doctors, we're not very good at having this conversation.
No, it's a very difficult one.
Yes, so it's understandable that we might sort of retreat from it a little bit. But when we have the discussion, a lot of people will, we discuss it in those sorts of terms. But a lot of people wouldn't want to be resuscitated.
No,
people
wouldn't.
People have the right to. We're talking about what they can choose and not choose. They can have the right to say, I don't want to be resuscitated, and even if I want to, I'm not allowed to, because it's their decision. That said, if he were to turn around and say, well, I want to be resuscitated, that would put us in a bit of a different position. He doesn't have the right to demand a treatment, which I don't think is in his best interests. But it would make it a little bit more of a difficult situation. Now, if he were to say, whatever happens, I want you to resuscitate me, I'd have to talk to the rest of my team, particularly my consultant, and see what he thought. As I say, it's not his. He can't demand that of us, but he is my patient, and I do want to do what is best for him, but I also want to do what he wants. And if he were saying, I want you to resuscitate me, that would be a bit more of a difficult decision. And I need to involve the rest of the team there, and we talk it through, and we'd let you know and him know.
Yes, that's good.
And it might be that our decision is that we would resuscitate him if that's what his wishes are, because I do want to respect people's wishes where I can.
I appreciate that.
But I thank you very much.
But it's better coming from you than me, because in his frame of mind, he might just think I'm being difficult and want to get rid of him, and I don't want to think I'm sort of talking behind his back, but I think he will come down in favour of it, because he's so fed up with life.
Well, I can understand that. So thank you for, I mean, it's a difficult topic for you to bring up, and I'm grateful to you for doing it, and certainly that's something we can move forward with and put in place.
Right, okay.
Is there anything else you'd like to talk about?
Well, no, because if I talk about anything else, it would be asking, what was going on with him at the moment, and I can't do that without you having permission.
That's fine. And you're going to come and visit him now? Or?
Yes, I'm on my way in. Okay.
So just summarising briefly, just to check
Yes.
It's good in case I've got the wrong end of the stick somewhere. So you've been suffering for a while along with him, and been his sort of chief carer and a sort of unpaid nurse in a way.
Yeah, but it's coming to an end.
And we feel that his quality of life is quite poor, and that should he die, that trying to bring him back wouldn't be, you feel it wouldn't be in his best interests, and it's not what you would want for him. And we as the medical team would agree with you.
This must be putting a terrific strain on him, and I think it's possible he might have a bad heart attack or something, because he's been ill now so many times, ill enough to come in hospital, and this is really what I'm thinking of. Okay.
All right. Well, thank you for coming in.
Thank you.
Nice to speak to you.
Okay, I hope that was, a spotlight for how you can conduct, conversation in different setting. Even the hospital setting, it will be the same conversation, or in the GP setting, more or less will be the same conversation. Okay, so I think that was, a very good conversation, and just give you an idea how to conduct such conversation if it's either in real life or if it appears to you in your exam, and then. After that, we might consider discussing the respect form. What is the difference between the respect form and the DNR form? Just go through the the PowerPoint and what are the respect form, how to fill in the respect form in the system, what are the important bits and how to fill it in, because sometimes you might find it confusing. All of that we are discussing in our webinar, okay, as well as the refusal of treatment, advanced decision of refusal of treatment, which will also see the PowerPoint of it. So, we might need to just slow down the video and see the PowerPoint slides, because I don't want to make the video, very long by going through them and explaining them. However, I'm more than happy if any one of you wants to discuss anything related to CPR or respect form or advanced care planning or living well, or just in case med, all of that, just please write below the video on the YouTube channel, or send me in the WhatsApp. I'll be more than happy, to guide you through all the question that's in your mind. And but please try to think of what are the scenarios that you can discuss with the coroner, and what are the scenarios that the midwife or the community district nurse team can discuss with you regarding the patient, because all of this, we are facing it as, full graduated GP and full functioning independent GP, everyday practice, and also if the practice is taking care of care homes, because some practices are affiliated to certain care homes, and they're taking care of them. And you'll find every day you will discuss with the nurse the cases, and chest infection, terminal illness, or Parkinson's, which we will discuss the Parkinson in detail in the oncoming weeks. Sorry, I promise I will discuss Parkinson's, but Parkinson is one of the topics that is very important. You will meet every day or every week in your GP land. Okay, what are the how you can diagnose this is from the differential diagnosis of tremors, okay, to the advanced care of the Parkinson's, to the complication of the Parkinson disease, complication of the medication, and then how you can help and support the patient during his life, okay, to come over the symptoms, and for sure the carer fatigue as well, how you can deal with it. All of this I will discuss in the upcoming weeks, okay. Please, 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 you know that our channel is completely free for your support. Okay, so please try at least to subscribe and share. Okay, so to increase the knowledge about my channel and about the effort that I'm doing, there is a Telegram, there is a WhatsApp group as well, and Facebook page. Recently I made it. And please, for any further support and help, I'm more than happy. You know that I'm doing one-to-one teaching or mini mocks, okay, teaching, as well as the free teaching that we are doing. So please, doctors, support the good work, okay? And if you like it, support it. If you don't like it, just say what are the negative points of the teaching, and then we'll try for sure to come over it if it's having a weight and concern. Okay, thank you very much, doctor. And please, lastly, don't listen to the negative thoughts. Don't listen to the voices that are saying you will not find work. No, you will find work. You will have a promising career, but just first finish the main step, which is finishing your exams, and then everything will be easy. Believe me, everything will be easy, and you will find what you wish. Okay? So do you continue your hard work, do your best, and lastly, just because I received some question, is it better to practice with a professional actor, or better to practice with the doctors? Well, I'm not sure what is the definition of professional actor, to be honest. Okay, and for sure, who's better, actor or a doctor? For sure, a doctor is better than an actor, without doubt. Okay, because the doctor know the medical knowledge, he can manipulate the situation according your level and put you the complexity that it's needed so to increase your level of knowledge. But the actors is scripted, so if you keep learning from scripts, I don't think that will be beneficial for you, either for the exam, neither for your future life, because you need to know you are studying now, not just to pass the exam. You are studying now to become a proper GP. So if your studies now is weak and not good, even if you pass the exam, in the future you will struggle. Okay, so better for you, to know how to tackle the complexity of the cases, and for sure that will be transferred to you through the experience from a doctor rather than from an actor. And however, it's just a query that was thrown to me in the last couple of weeks, and I needed just to share my thoughts about it. And it's completely up to you, for sure, doctors, to prepare for your exam, but I'm here to support. Whenever you want any help, any support, just let me know. If you want to keep practicing on the, Wednesday teaching, I'm more than happy. We can take more than candidates rather than one candidate. For sure we can consider that. Because originally we were doing two cases, but then I think that people find it overwhelming because you are taking the theoretical part of it as well. But I'm more than happy. Just give me your suggestion, and we'll try to do our best to help you and support you. Wish you the best. Keep the hard work. Finish your exam, and you will find work. Bye.